lumbar spinal fusion. A spinal fusion is a surgery which connects two or more vertebrae, eliminating the motion between them. And it involves techniques designed to mimic the normal healing process of the broken bones. So what your surgeon will do is place a bone or a bone-like material between the space between the two spinal vertebrae, and then he will fuse them using screws, plates, rods, so that they heal into one solid unit. And there are different approaches to a lumbar surgery. Okay, we have a posterior approach, anterior approach, lateral, oblique, and the difference between this is the approach to the disc space and the structures that are in the way. So as you can see in the picture, in posterior fusion, the approach is from behind through the bone to get to the disc space. In the anterior fusion, the anterior approach, the main concern is the major blood vessels. So the lateral lumbar fusion, or the XLF, which is called, it's a more direct lateral approach to the disc space. So it goes through the muscles and the structures. So why do they prefer the lateral lumbar fusion? And some thoughts are because it's minimally invasive, so there's a faster recovery. It's a direct approach to the disc space. It keeps the posterior ligamentous complex intact. It avoids the major blood vessels, so this reduces blood loss. And it's also thought to allow for better cage placement and promote a stronger fusion. Now, what is intraoperative neuromonitoring? Intraoperative neuromonitoring, or IONM, is the continuous surveillance of the patient's nervous system, the brain, the spinal cord, and the nerves, which are at risk during surgery. And the purpose is to protect the nervous system. What you require is a trained clinician or a surgical neurophysiologist who works under the supervision of a physician and who constantly monitors the information from these tests. So when significant a change is detected, the team provides immediate feedback to the surgeon, anesthesiologist, and the nurses, and they respond quickly to minimize the changes. So there's a decreased chance of long-term post-operative injury. And intraoperative neuromonitoring provides an extra layer of safety for both the surgeon and, most importantly, the patient. What are the most common modalities that we monitor in IONM? One is the SSEPs, or the somatosensory evoked potentials, which monitor the whole sensory pathway. And we have the motor evoked potentials, which monitor the motor pathway. Then we have spontaneous or live EMG, which is a live muscle response. And there's the triggered EMG, which means you send an electrical impulse and then you record a muscle response. And the train of 4, which is used to monitor the degree of neuromuscular blockade. So ideally, you would like to have 4x4 twitches, and the number of twitches corresponds to the level of blockade. So if there's 1 out of 4 twitches, then there's a 90% blockade at the neuromuscular junction. 2 out of 4, 80%, and so on. And for motor evoked potentials and EMG, the ideal is to have 4x4 twitches, which is no blockade. And then we also monitor EEG, which is the brain waves, and it's usually monitored as an adjunct to anesthesia to measure the depth of anesthesia. So let's review the procedures or the steps of a lateral lumbar interbody fusion. One is the positioning, which is a lateral decubitus position. Next is gaining access to the disc space, which the surgeon does through placing dilators. Then they do the discectomy through the dilators, and then ultimately placing the implant. And so let's look at the steps in detail and see what's at risk in each step. So the first step is positioning. So let's take a look at this lateral position, where the patient is positioned lateral. The rolled towels or padding is placed under the axilla, under the knees, between the legs, and under the flank to elevate it. Then the knees are flexed and then taped. And this all translates to pressure or compression, and on both sides of the body, more so on the lower side. Then the table is jackknifed, which translates to stretching, which is the mechanical stretching of the psoas muscle. And so essentially there is pressure everywhere. And the main concern here is the peripheral neuropathy, which is caused by compression of the nerve on the lower leg. And how do we prevent this? By monitoring the peroneal nerve on the non-surgical side and the saphenous nerve on the surgical side. We also monitor the ulnar nerve for the uppers and the posterior tibial nerve SSEPs for the lowers. So let's look at the peroneal nerve. So why do we need to monitor the peroneal nerve? And the peroneal nerve is a branch of the sciatic nerve. It supplies movement and sensation to the lower leg, foot, toes, and is responsible for dorsiflexion of toes. It traverses on the outside of the fibula, below the knee. The knee is flexed, and lying laterally is a perfect way to put pressure on this nerve. So injury to this nerve causes foot drop, which is the inability to dorsiflex the foot, and it drags when walking. So when you sit with your legs crossed for a while, that's the nerve that makes your leg feel tingly and hard to move. So if you look at the picture here, that position is where we would monitor the peroneal nerves by placing electrodes along its path of travel. And the stimulation parameters will be the same parameters as you would monitor a posterior tibial nerve. So you would use 30 to 50 milliamps of intensity and then record for an average of about 300 sweeps. So next is the saphenous nerve. So why do we monitor the saphenous nerve on the surgical side? Why is the saphenous nerve important? It is important because it is the largest sensory branch of the femoral nerve, and it innervates the medial portion of the lower leg and the foot. So this is another place where there's pressure during positioning. So more relevant sensory information is gathered from the saphenous nerve during laterals. Another reason is it is part of the femoral nerve, which is at risk in this procedure. Therefore, it has more relevant information than the posterior tibial nerve, which is not so much at risk. Now, the saphenous nerve is a deeper nerve, so you would require longer needles for it to work better and get better responses. And there are two sites basically where the saphenous nerve can be accessed. One is proximally between the vastus medialis and the sartorius muscle on the thigh, and distally between the tibia and the gastrocnemius muscle. The distal side is more accessible because of body habitus. Like people usually tend to have more fat in the thighs than opposed to the leg, so it's more accessible in the distal region. And these are lower amplitude responses as compared to the posterior tibial nerve responses. And they also may require a little longer pulse width to get a much better signal from them. As you can look at the pictures of here, they're not that well defined, but you can still make out the signal. So the next step is access to the disc space, and this is the most critical part, and this begins immediately after incision. So the most common way the surgeon accesses the disc space is by using dilators, which are followed by retractors, as you can see in the picture. And the nerves that are at risk are not only from direct nerve injury, but they're also at risk from traction injury from the retractors. So what we're doing here is we're cutting through the psoas muscle to reach the disc space. The greatest risk here is to the lumbar plexus and the femoral nerve, which pass through the psoas muscle. And we know the lumbar plexus is formed from the T12 to the L5 nerve roots. They join to form the lumbar plexus. Now the nerve roots L2, L3, and L4 join to form the femoral nerve. And the femoral nerve is responsible for the hip and thigh flexion through innervation of the quadriceps muscles, and it also is responsible for sensation to the anterior thigh. So our job here is to help identify a safe path to the disc space, mainly focusing on the lumbar plexus and the femoral nerve roots. So we use EMG, which is live EMG or electromyography, and then we use triggered EMG. Triggered EMG is where you would send stimulation through a probe, and then you would record responses from the specific muscles innervated by the specific nerve roots. So you can give the surgeon an idea as to how close they are to the nerve roots and how much space they have to work with. And then you also do motor evoked potentials. Now the saphenous nerve SSCPs, which are the sensory SSCPs, are also shown to be significant, especially during retractor placement. So let's look at the lumbar plexus. Now we know the lumbar plexus is formed from the T12 to the L5 nerve roots. So the EMG or the triggered EMG muscles are selected to cover the lumbar plexus and the femoral nerve. And the most important muscles which are supplied by the femoral nerve are the quadriceps, which include the rectus femoris, vastus intermedius, vastus lateralis, and vastus medialis. So the most important muscles that we usually choose are the vastus lateralis and vastus medialis, more because they're easily accessible. And they each need to have their own channel to get more specific information. Now, we also monitor the adductus longus muscle. Why the adductor longus? Because it is supplied by the L2, 3, and 4 nerve roots, same like the femoral nerve. But this is the obturator nerve, which is also formed from the L2, 3, and 4 nerve roots. And so it's at risk too. Then we do the abdominals, which is supplied by the upper lumbosacral trunk, and the antiband gastroc, which is supplied by the lower lumbosacral trunk. So we're covering all this to monitor these muscles during the procedure so we can give more specific information to the surgeon. And we use these same muscles also to record motor evoked potentials. So let's see, what do we do to guarantee or rather identify a safe path for placing dilators and retractors to the surgeon? So we use triggered EMG, where stimulation is delivered through a stim clip which is placed on the dilators, as you can see in the picture. And the current passes through the probe, and the muscle responses are recorded from the muscles innervated by the specific nerves. So the safe threshold is around 8 milliamps. So anything that measures over 8 milliamps is said to be clear of the nerves and is part of the safe path. And the lower responses indicate that you are closer to the nerve. So that way a safe path is identified. And once the safe path is identified, then the dilators and the retractors are placed. So after the retractors are placed, the surgeons also do a 4-quadrant stimulation using a probe. So they place the ball tip probe in the disc space, and they do the same triggered EMG method where you send in stimulus and then you record from the muscles. And they measure all the 4 quadrants to make sure that they are clear of any nerve structures that may be present. So a lower response would indicate a closer proximity to the nerves, which they would like to avoid. So like we were speaking about, now we will talk about the motor evoked responses. Why motor evoked? Because the femoral nerve is at risk, not just the L2, 3, 4 nerve roots by themselves, the whole nerve is at risk. And the motor evoked responses are more specific to a nerve than just the nerve roots. So EMGs will identify the nerve root proximity and nerve injury, but motors will identify a developing nerve dysfunction. So even if just a nerve root is damaged, like just the L2 or just the L3, you would still get a motor evoked response. But if the whole nerve is damaged, then you will not get a motor evoked potential response. So it's important to have 2 quadriceps muscles for this, because a significant motor loss in the quadriceps corresponds to a complete nerve damage, and this is something we would like to avoid for these procedures. And like we discussed, the muscles would be the same, two muscles of the quadriceps. So in total, what would this multi-modality intraoperative neuromonitoring protocol look like? So in addition to a regular lumbar protocol where you would do an ulnar nerve and posterior tibial nerve somatosensory evoked potentials, you would also do the saphenous nerve somatosensory evoked potentials on the surgical side, and the peroneal nerve on the non-surgical side. It would include motor evoked potentials from the quadriceps, at least two of the quadriceps, and the adductor muscles. Then the EMG muscles will include the abdominals, the quadriceps, and the adductor muscles. Then you would do triggered EMG or testing with the probes, and then train of 4 to make sure we have no neuromuscular blockade. So for effective EMG and motor evoked potential testing, TIVA or total intravenous anesthesia is preferred, where there's no use of gases, so that our signals are not dampened, our cortical responses are nice and robust. And then we have to make sure we have 4 twitches or there's no neuromuscular blockade to be able to monitor the responses. And for the final stages of the procedure, which is discectomy and then the implant placement, all modalities are important, but EMG and MEP or motor evoked are the most significant. So to summarize, the greatest risk in the lateral procedures is to the lumbar plexus and the femoral nerve. And the common post-op deficits are hip flexion weakness due to quadriceps weakness and decrease in anterior thigh sensation. This is due to damage to the femoral nerve. And the most feared complication is permanent injury to the femoral nerve, both sensory and motor. And intraoperative neuromonitoring helps in preventing that complication by adding to a regular lumbar protocol, peroneal nerve SSCPs on the non-surgical side to monitor for peroneal nerve compression, saphenous nerve SSCPs on the surgical side because it is a sensory branch of the femoral nerve and gives surgery-specific information. And you also need to add the quadriceps muscle, which is most significant because of the femoral nerve involvement. And you at least have to monitor 2 of the quadriceps individually. And also the adductor muscle due to the obturator nerve involvement. If you have limited channels, you need this coverage only on the surgical side. So on the non-surgical side, you can run a limited lumbar setup, just doing the ulnar nerve and posterior tibial nerve SSCPs and EMGs. Now the EMG and the motor evoked potentials and the triggered EMG help in identifying a safe pathway to the disc space. The motor evoked is more specific for developing nerve root dysfunction. And there may be significant changes in motor evoked potentials with no changes in SSCPs or EMG responses, just because the motor evoked responses are more specific. So why we do all this is to prevent a femoral nerve injury, because a high-grade femoral nerve injury is more debilitating than a single nerve injury. And motor evoked potential responses from the quadriceps helps significantly in preventing any sort of neurological damage. And that's all I want to talk to you guys about today. Thank you so much, and I hope everyone has a great day.
Thank you, Nimesha, for your illustrations and wonderful presentation. And lateral lumbar interbody fusion is minimally invasive, and particularly it has gained popularity over last decade. But along with clinical and radiological advantages of